I think there are a lot of reasons I wound up doing what I'm doing, but I'm a primary care internist, and my interest really peaked in the mid-1980s when I was a medical student in the Bronx. We had lots of HIV, and I did a 12-week rotation at Jacobi Hospital, which is Bronx Municipal, huge hospital in the middle of the Bronx. And in a night, we typically admitted 5 people, all with the same diagnosis. And on the board where we looked at patients, we'd put their names and what their diagnosis was, and everybody was an SWAF. Does anybody know what an SWAF is? So SWAF was the lingo for a shooter with a fever. So everybody was a SWAF. And all we did for SWAFs was we drew blood cultures and made sure they didn't have a blood infection that might have given them endocarditis. And then they went left. And I remember saying to both my resident and my attending, this doesn't seem like we're really addressing the problem. What are we really doing for these patients that we're watching them for a day and just drawing some blood cultures? And the answer was, there's nothing we can do. So that stuck with me, and that's why, as we unfold the picture today, I want to offer, and as you all know, I'm not preaching to the choir, that there clearly is something we could do, and in 2014, there's a lot we can do. So it kind of became my mission. I always liked, when I was a kid, doing the extra credit or doing the problem that the teacher would say, this is really hard. So it was easy, I wasn't interested, but if it was something that someone said, there is no answer, or that this is hard, that meant that was something that I wanted to figure out. So I'm going to start off with that as the introduction. So what I'm going to do today, this is, again, no disclosures. I have no commercial interests. To increase knowledge about opiate use disorder, increase knowledge of treatment, and I'll paint you a picture of what I'm doing in terms of trying to address it in the primary care setting, and also to give you some data, which is evolving, and I'll give you some ideas about what I'm going to be looking at going forward, that integrating treatment for opiate use disorder with medical care is beneficial. And I think that it's beneficial to all 3 pieces, right? So I think it's beneficial for the patient, which I think is most important. As a provider, it gives greater satisfaction. And then I think it also is beneficial to the health system, and I'll show you that as well. We're going to go through a long path. So some of this you know. So in 2010, with 22.5 million people with substance use disorder. We know it costs a lot of money. And then in 2010, there was also recognition specifically related to opiate analgesics, not just heroin. So you can see 2010, 1.9 million people with opiate, and you can see the majority are non-heroin, and that's still true. And you heard yesterday also that there are now more deaths related to accidental overdose than motor vehicle accidents. Back in 2006, Institute of Medicine released a report saying we need to coordinate mental health and substance use with general health services. So this isn't a new topic. Right? There's a call for it, that was 8 years ago. There's been calls for it dating back obviously much further. And that there should be studies of healthcare delivery and health outcomes in order to make best decisions and proof of what the best care should be. So I'm going to open this up. Some of you are far away. This is just to get you peeked as to some of the people. Who are the people here? Upper left, you can yell. John Belushi. Upper right.
Jerry.
So how many people are Jerry fans? so Jerry Garcia. Lower left? Brett Favre. Lower right? Rush. So the only reason I especially include Rush is because unfortunately Rush still lives here in the country. He said if the Accountable Care Act came to be, he would move to Costa Rica, but he's still here. So all of them had opiate dependence, right? So in a way, it was a good thing, right, when you see people in the public eye, including Rush Limbaugh, to realize how it pervades all types of people. Now, he was very much in the news, right? So a couple months ago, all of a sudden, the media is interested again in opiate use disorder, right? Someone famous, oh my God, this person, is at the Academy Awards, they've been in all these great movies, and they have opiate use disorder. How could he use? How could that be, right? So I got calls, through our Hopkins Public Affairs for reporters who asked stupid questions. Like, why would someone who has a lot of money use heroin? Right? What does that have to do with it? Right? So there's a still general public misunderstanding of addiction, and you can see that this is just a description that he had a lot of heroin. He was actually, interestingly enough, had heroin that we know in Baltimore has caused a lot of overdose deaths as well. That was laced with fentanyl. And the other interesting thing about when you hear about Philip Seymour Hoffman is that the next day in the news, I don't know if people noticed this, but it bothered me, is there was a call to find out where he got his drugs. So it's the fault of the person who gave him the drugs that he overdosed, rather than saying this is someone with addiction. And so they went searching for his dealer, and they actually arrested his dealer, who turned out to be a musician that he really just used with. I don't know. Any other reactions to him? Other people that create conversation around you? Go ahead.
I know for me that it's always sad that there's, because it knows a needle stuck in his left arm. I know one of the reasons why I'm in the treatment field today was I was a gopher at a treatment program, and someone went home and for the weekend. His mom found him dead with a needle in his arm, and they didn't make the national news.
Yeah.
You know, he had his any basic text open, and then he had the needle in his arm, and his mom found him when she went to wake him up the next morning.
Yeah.
So it's sad that somebody famous has to die to bring attention to something that happens every day.
And it seems to come in a wave. It's going to peter out over the next few months. All of a sudden, this won't. The tension will go away. So what about if he asked you for help? So who's that? Anybody know? So that's William Halsted, one of the founding fathers of Hopkins, who was a surgeon. So this is just to show that it can happen to actors, and this is not a new problem. So William Osler, who was the medical god of Hopkins, kept a diary, and the diary actually was opened about 40 years ago. And this is what he wrote. According to most first-hand accounts of his days at Johns Hopkins, Halsted, by the way, Halsted is the one who created sanitary technique that before that surgeons didn't wash their hands before they operated. So William Halsted is the one that says you should wash your hands and put on gloves before you do surgery. Surgeons before that wouldn't wash their hands, and they felt that they couldn't do surgery if they had gloves on. So it's a good thing that despite the fact, anyway, he was moody, elusive, sarcastic, and prone to dropping out in the middle of an operation. You would think most of us don't want our surgeon to drop out in the middle of the operation. William also recalled in 1890 that he had seen the surgeon having severe chills. Suspecting that Halsted was still addicted to morphine and was going through withdrawal, Osler gained the surgeon's trust and confidence. Came out that Osler actually had a syringe in a vein in his leg that he could actually inject using his other foot somehow while he did surgery to give himself more morphine. So in a secret diary that Osler kept, Osler wrote, Halsted has never been able to reduce the amount to less than 3 grains of morphine daily. And this he could do is work comfortably and maintain his excellent physical vigor. I do not think that anyone suspected him, not even Welch. So Osler hid for his colleague, right? He didn't confront him. He essentially hid him. And later on, there's reports that Halsted went to a sanitarium up in New York to get himself drug-free, but he lived his entire life intermittently addicted to both morphine and cocaine. There's a book called Genius on the Edge about his life that points out the chaos of his morphine and cocaine addiction. Many of the greats at that time, Sigmund Freud, many of the greats used both cocaine and morphine intermittently. So I'm going to bring it, so they weren't my patient, but this is my patient. And I want you to think about, I'm a primary care physician. I'll tell you more at the end about how my practice has evolved. But again, I created my practice in 1994 as a practice to take care of and focus on the care of patients with substance abuse in the primary care setting, a place where people could be comfortable. I had joined the faculty and medicalized. We have an inpatient detox unit, and realized there wasn't a place to send these patients after they finished their detox, a place they go for support and really addressing all their medical problems. So this is 2014. So this is January 2014. So a 28-year-old woman seen for first visit, was able to review in her electronic health record, again, importance of electronic health record, visits with other providers and ER visits for back pain wanting opiates. So I had records. I didn't have to wait for records to come to me, and that's the beauty of an electronic health record. I reviewed CRISP. Does everybody know what CRISP is? So CRISP is a system where I can go through a portal, and all hospitals in Maryland have to input It's still missing some stuff, unfortunately. I had a patient who was hospitalized in the Eastern Shore and that hospital didn't input. But I could see imaging studies, lab results, discharge summaries, as well as prescriptions. So I was able to go in the system and see that she'd been in a variety of ERs around the Baltimore metropolitan area and fill scripts for oxycodone. Her other medical history was she had abnormal PAP 3 years ago, a history of hypertension, elevated blood pressure today, not on blood pressure medication. And her agenda, which was obvious because I used to make a list, what's your agenda? And her agenda was getting a script for oxycodone, and my agenda was getting her engaged in medical care and treatment for opiate dependence. So we'll return to her towards the end. So this is, remember, so there's some divergence here, but at the same time, I'm going to show you that we do converge at the end. Step back. I think it's interesting to think about how did we get here, to borrow a line from the Talking Heads. So opium was first known 3400 BC, and it was called the joy plant. So long, long time ago, people knew about opium. So the Greek gods wore poppy wreaths, and it's interesting, the three gods that wore poppy wreaths were the gods of sleep, night, and death. So those ancient Greeks knew something, right? So they knew it before Philip Seymour Hoffman. And then the Persian physician, again, a long time ago, made use of opium in anesthesia and recommended its use for the treatment of melancholy, right? So this is 9th, 10th century. So between 400 and 1200 AD, Arab traders introduced opium to China. I always, years ago, thought, before I started being interested, that opium started in China. It actually came to China. Ottoman Empire, opium was used to treat headache and back pain. 14th century, we had people who were abusing opium for backache. See that? 15th century, first recorded use of opium as a recreational drug. 1974, heroin was developed. We're going to go into the types of opium quickly in a second. And in 1898, heroin was marketed by Bayer as a safe pediatric cough suppressant. And this is an ad. So you can see Bayer Pharmaceuticals. It was aspirin and heroin together. And you can see it said the sedative for cough under heroin. It's taken off the market a few years later. So just the top picture is a picture of the poppy plant that's all over Afghanistan probably right now. The majority of, over 95%, is grown in Afghanistan. Do you know in the United States, one of the problems with morphine, which obviously has a use, is that the United States cannot produce, grow, or do anything related to making opiates. For a while, there's been a question, especially for morphine, which is used parenterally, how to get it. But anyway, so opiates. So many, and I apologize if I do, a lot of us use opiates, opioids intermittently, but strictly speaking, opiates are natural present in opium. So the opiates are morphine, codeine, and thebaine. Opioids are manufactured. So we often confuse the term. I even do it too. So opioids, heroin is made from morphine, and that's why if you do a drug screen, they cross-react, right? So it usually comes back together when you do a drug screen. Heroin and morphine are similar. Buprenorphine is derived from thebaine, and that's why if you want to look at buprenorphine in a drug screen, you have to test for it separately. And then there are synthetics, which are completely man-made, and that's methadone. And that's, again, why if you want to look for methadone in urine, methadone is reported totally separately. So the grouping is, and oxycodone is, for the most part, is also semi-synthetic, but in larger amounts it cross-reacts with heroin and morphine. In lower amounts it doesn't, so generally we do ask for it to be tested separately. So what about narcotics in the United States? So William Halstead, if he had asked for help, could have gone to a doctor's office and gotten decreasing doses of a tincture of opium in an attempt to detox him. So if he walked into my office, I could have said, here's some liquid opium, here's a schedule to take it. Until 1914. So starting in 1914, a physician could no longer say, I can help you. You're addicted to morphine, I want to help you. The only thing they could do after 1914 until 50 years later was say, you got to be around people and you're going to detox and be really sick. In so the Harrison Narcotics Act prevented any prescribing of narcotics except for pain. In 1925, a physician sued and said that this is illegal, you're hindering the way I want to practice medicine. He won, but it didn't change the Harrison Narcotics Act. In 1964, finally, 50 years later, without much in between, methadone was introduced as an experimental treatment for opioid addiction, and I'll show you the data behind that. Yes. And then in 1968 was the birth of the Bureau of Narcotics and Dangerous Drugs, which became the DEA, just as a... So this is kind of opiate use disorder. Remember, we've kind of gotten away from dependence and abuse, although most people who run into problems with opiates will become dependent. So if you use long enough, you become dependent. You know, but we have to differentiate, for instance, dependence versus addiction, right? So someone who has, burn injuries and needs to be on opioids for 3 months, they're dependent on them. They have to be tapered off, but that wouldn't define addiction. They're taking it as prescribed. But they'll have withdrawal if you try to stop it abruptly. So in terms of a disease, we think of these things, which is tolerance. So people with chronic pain syndromes don't necessarily develop tolerance. They can maintain pain relief at same dose without tolerance. But if it's used for euphoria or to get other effects, they will have tolerance and need larger amounts, try to cut down, not be able to, and I think you know all the others. So here's my bias. So I know there's a talk on Espert, and you heard yesterday that there are studies that show that Espert is pretty limited, and I'm going to say that if we're talking about integration, we're not interested in screening and then referral for treatment. We're interested in which is I advocate, and I hope will come to be more and more settings, which is screen, intervene, and treat. The piece missing in Espert is between the R and the T, right? How many of those people that you, quote, refer wind up in treatment? And if you can provide everything you can in one place, you don't have to worry about the R, and you don't have to worry about that gap. In East Baltimore, at East Baltimore Medical Center, there's a study looking at people, a little over 200 people, they, quote, did Espert and referred for treatment. 8 people wound up showing up at the treatment site, 8 out of 200. So that's really, really pretty awful. So I think we have to be careful with Espert. There are ways to make Espert better, having a community health worker accompany the person to that to that referral. So if you have to do Espert, there are ways to do it. But if you're just going to give a piece of paper, refer to treat, I think we're missing something. So interventions and education are effective. Whenever I intervene, just quickly, I always emphasize benefits, right? I use family and friends in a positive way. I try my best to undo shame. So there's a lot of shame. So a lot of addiction is full of shame, full of low self-esteem. So I have a cartoon I share with patients where a provider says to a patient, the best thing you can do for yourself is not use drugs, not drink. It actually says not drink. And the patient says back, I don't deserve the best. What else can I do? So think about it. That's where our patients are. They're pretty low. And you have to do some, I always try to do some convincing and figure out what would get better if you didn't use. And I also specifically always say to patients, you never have to say, I didn't like heroin. You used heroin because you liked it. You like getting high. But here's the reasons why we should intervene here and get you in treatment, because these are the things that will get better. And implicit in saying that is that there's hope that you could succeed. My patients are, we work together. And you'll see later that it's not just me, it started out just as me. But I turn to patients, and this is for all of you too, is as we engage patients with a team approach toward recovery, is that you now have a fan club. And we identify the pieces of their fan club, meaning health team fan club, family fan club, friend fan club, and we try to identify who their fan club is as they work toward recovery. So this is what we want. So I don't know if you can see in the back, it says, someone in the water, it says, Lassie, get help. And then Lassie is lying on the couch getting help. So that's what we want. We want all our patients to get help. So this is traditional 12-step drug treatment. And as you heard yesterday, I think this is the basis. So even as most of what I'm going to talk about today is incorporation of pharmacotherapy and for opiate dependence, this has to be there. someone said yesterday that the medications is the hamburger helper. I think that's right, that this has to be the basis. And even though I'm going to show you some studies that by sending people to augmented counseling doesn't necessarily change, it's because they still have to have this in the background. So I cut it down to 7 pieces because I left out some steps. It's like leaving out some of the 10 Commandments, I know. But it's kind of the pieces that I think that people have to highlight. Obviously, some of the steps are making amends and not making amends if someone else doesn't want it and giving back. So I think those are all kind of in there, but I think this is the key, pardon me for if I've done this, but the key aspects of 12-step belief. And I think it's pretty tough for patients to say, no, this isn't right, right? I mean, anybody who wants to succeed kind of has to say, that I need to do what I can I have to abstain. I haven't been able to control my use. It's okay to accept this disease because it takes away blame from me, but I accept responsibility for what I have to do to change my life. I need people around me to support me who don't use, the right people, places, and things. And I have to put myself, again, the last one is people, places, and things as well. So it's pretty tough for anybody to succeed without doing these. We'll come back to that at the end, too. So what was the rationale? And by the way, people can interrupt. Yeah, go ahead. I was just going to say you can interrupt.
I wanted to just make the comment and
Go
see
ahead.
what you think in terms of the 12 steps. The problem we find, at least with those that are in our Suboxone group, is that they're absolutely shamed with NA because they have such a philosophy of if you are on Suboxone, you're using.
So good question. So we have to change. Yep. So we have to change some of that philosophy. I do know of meetings where people on buprenorphine are welcome, methadone as well. For a while there were methadone anonymous meetings, but I work at Dee's place on Monday morning where this was a community recovery center that has probably 100 NA and AA meetings a week. And I met with them. It was work because these people, the people were very 12-step, but they now accept the fact that we have patients here who weren't succeeding just with 12-step. And maybe you're right that for some people they need more than just this. It's a process. Yeah. So,
They're not doctors or clinicians or counselors.
Yeah.
They're addicts helping other addicts.
Right. So I tell people when they go to the meetings, don't announce you're on buprenorphine or methadone, but eventually, listen, and then all of a sudden there's a process. So I take care of many people on buprenorphine who are now comfortable at speaking, but they've also found specific meetings that make them feel okay. If you read closely within the booklet, there's nothing that says you can't use pharmacotherapy, medication. In fact, it even alludes to the fact that doctors are part of the recovery process, or providers, that accept other people. So the rationale for opioid replacement therapy, and originally it was methadone and LAM, which is no longer available because of cardiac problems, right? So if we occupy the mu receptor, and there's always something there that will, something that's long-acting, oral, will prevent withdrawal and craving, right? Once you've taken that dose, you won't feel it, and I'll show you that in a second, especially for methadone. That will extinguish compulsive behavior. And again, 1980s, prevent spread of HIV, hepatitis C, so if people aren't using needles anymore, and prevent criminal activity as well. So this is going to be the only slide about naltrexone, but I think you have to know that naltrexone can be useful. So naltrexone is an oral form of naloxone. So it's a pure opiate blocker. It's available both as an oral drug and a monthly injection. For the most part, acceptance is poor, but if people accept it, it works really well. So it's how you get people to take it. So I've participated over the years in several research studies. And in research studies, it does work really well because there's a contingency that says they have to take it. So for instance, right now, I work with Ken Silverman. We have a program where we, through drug court, we take commercial sex workers and give them job training. Data entry skills, computer skills, if they need GED training, GED. And they get paid. But in order to enter the workplace, they have to, initially it's oral naltrexone and then injectable naltrexone, but they have to accept naltrexone in order to enter the workplace. So they accept it. Once they finish the program, the acceptance is pretty low, although many of those people after 6 months or so still do well. So most of the data looks at has to be a contingency that makes you have to take it. There are also studies of professionals, so physicians who, as part of getting back their license, have to be on naltrexone. There's something tied to saying, I need to take this, otherwise something bad's going to happen, or hopefully something's good going to happen. So those are the groups. But in regular primary care clinical practice, the utility is pretty low.
A lot of the research has shown that, Vivitrol and whatnot is very effective in preventing relapse, and there's some really good science on it. And also that it's really convenient, you only have to get it once a month, you don't have to keep going to the methadone clinic to get it. So why do you think acceptance is so poor for it as opposed to methadone or Suboxone?
So I think there's a bunch of reasons. One reason is that I think it doesn't give the, so I think there's some, I'll take a step back. For a lot of people with opiate dependence, there's something different about their brain chemistry. So for instance, 10% of us, if we're exposed to morphine or heroin, will not like it, and we will have zero risk of ever becoming opiate dependent. And for many of those people, there's something different about the receptors, so they don't feel the same unless there's something at that mu receptor. So that's one reason. Second is some people don't like getting an injection. You're correct, it would seemingly be convenient. Insurance coverage has been not always as good. It's not unreasonably expensive because it's once a month. So if there's it's $400 for the injection, which is a lot. The injectable form for opiate dependence was approved based on there's been no U.S. study. So it was approved without any U.S. study, which was a little bit surprising. It was based on a study actually in Russia. In Russia, there's a lot of popularity on naltrexone for opiate dependence. There is not availability of methadone or buprenorphine, so it's readily accepted because there's really little else. So I think it's something that I think about, but the acceptance is pretty low. So, and if you ask, the other fact is that if you have a patient who has a history of overdose, who's ever had a reverse naloxone, and you tell them it's the same medication, there's an aversion to thinking that I'm going to have that medication in my system all the time. But I think I purposely included it because I think about it as I see patients as well. I'm going to get all these on here. So in 1997, an NIH consensus conference was called, and these are the bullet points. So opiate dependence is a brain-related medical disorder, and treatment is effective, and this is the statement. Although a drug-free state represents an optimal treatment goal, research has demonstrated that this goal cannot be achieved or sustained by the majority of opiate-dependent people. And I'll show you some of the data from the 60s, why this was said. And there was a call to reduce unnecessary regulation of long-acting agonist treatment programs and improve training of healthcare professionals in treatment of opiate dependence. Oops. So at the same time, remember, we're having a lot of non-medical use of prescription opiates, especially in young people, which is pretty scary. And again, these are some of the cost data, $20 billion related to total costs, healthcare costs, job costs, non-medical costs. So these are some studies from the 1960s where they looked at people. Each of the small circles is when people use. So this is just to think about the life of someone who's using heroin. So they wake up in the morning, and how do they feel? They're sick, right? So one of the things I always say to people as they get into treatment, just think tomorrow morning you're going to be able to wake up and not feel sick. So they wake up sick. They use, right? So the circle is using, and then they get high. And then through the day they use, another 3 times. Anytime they kind of feel the high kind of fading, they use again, they go to sleep, and what happens the next morning? They wake up feeling sick. But if you look at this, the majority of the time, they're either sick or high, right? So how much of the time in there are they feeling just kind of straight and okay? Very little, right? So most of the time, sick or high, and a lot of times sick. So the next day, they may not have been able to use as much, so you see there's a longer gap before they used again. Remember, heroin has a pretty short half-life. So it was thought that repeated exposure to short-acting opiates actually leads to adaptations. Eventually, you feel, the time it takes to feel sick diminishes. And as a result, you get tolerance, you get craving, and that's why we needed to think of ways to change that, the fact that people spend most of their time not feeling normal. So this was a look at dosing someone with methadone. So you could see where the M is. They take a dose of methadone, they're in the middle, and then again, the next morning they get a dose of methadone. And then you could see the third circle there, they used some heroin, and because the receptors were blocked, they went up a little bit, but the fact is they didn't feel it as much, so they still kind of spend the time in that feeling of straight. So that was the idea behind methadone. These are studies in the 1960s. So this is an illustration, a way to think about, and I think it's a nice, it's small, but I think it's a good illustration of just a small cohort of people in a randomized trial that was 30 years ago. So they, at baseline, randomized a small number of people, 17 people who are heroin users, to methadone or regular outpatient with counseling. You can go to NA, and then they followed them over time. So after 2 years, I'm going to interpret for you, in the people who are not on methadone, it's hard for you to see, but there were 2 deaths, the full black are deaths. There were 3 people who had bad medical outcomes. There were 2 people who wound up in prison, and all but 1 person at 2 years was using heroin. So there's only 1 person out of 17 who was not using heroin after 2 years. In the methadone group, there were 3 that intermittently were using heroin, and there were 2 that wound up in prison, but the other 12 were doing well. 5 years. So they just made a decision after the 2-year data that people would cross over. So if you weren't doing well, you could actually go back on methadone. So 9 people wound up back on methadone. At only 5 years later, of the original group of 17, 5 were dead. So really high mortality. And then you can see 2 others in prison. Again, that 1 person still doing well. So pretty awful. And then you can see in the methadone group, most of those people who had gotten back onto methadone, of the 9, 8 of them were doing well. 1 was incarcerated. So this was just to look at a naturalistic way of saying what happens to people if we try to see how they do drug-free versus on methadone. This is, again, this doesn't say that there aren't necessarily people who can do well, but at the same time it recognizes that if somebody's struggling, those people need to get help. So this was a study looking at what about injection drug use. So what happens to people who leave methadone treatment? They use injection drugs again. So you can see, even in treatment, and this is true at most programs, probably about a quarter of people at some point in treatment are occasionally using intravenous drugs. Sometimes it could have been cocaine as well. But as they leave treatment, by a year, 82% were using injection drugs again. So huge numbers. This looks at, the flip side looks at people who are in treatment, and to show that over time people diminish and they have less and less risk of using injection drugs in any way. So at the end of a year, there are still some people who injected minimally. A lot of it was cocaine as well. But then as time goes on and people are in treatment, the likelihood of injection drug use diminishes greatly. So what else should we look at as we think about people getting on opioid replacement therapy? Again, so this is methadone data from the 90s as the HIV epidemic was hitting, right? So people on methadone, seroprevalence of HIV, 15% or so. Look at incidence in people who are out of treatment. Again, this is incidence, so it's new cases of HIV. Seroincidence, that's hot by the 3rd year, as high as 37%. So opioid replacement therapy is HIV prevention as well. So what were the problems with the system in 1999? So we estimate even then was less than 20% of opioid-dependent patients receiving treatment in traditional settings, which was methadone programs. Sometimes there wasn't good enough clinic retention. It had to be 18. There's an infrastructure of care, and many states did not even have methadone programs, so a lot of people didn't have access. So Data 2000, which surprisingly was a well-received act. It was one of the co-sponsors of the bill, just be aware, was Orrin Hatch, who's thought of as being rather conservative politically, but realized this was a health issue, and there may have been other family reasons for all we know, but was a strong advocate of Data 2000. And Data 2000 allowed qualified, and I have to say that I think this was a mistake, but physicians, that should have been providers, to treat opioid dependence outside methadone facilities. And again, there are 3 ways that physicians could be qualified. The DEA would issue a free to qualifying physicians a new DEA number. It's called an X number for most physicians who are doing it. To use for medication for opioid dependence. It didn't specify the name of the medication, but as of today, only one medication formulation is approved for this use, and that's buprenorphine. Right now, there's, especially with the realization that of physicians who have their X number, less than half have ever written a prescription for buprenorphine, that there has been, on my part, a long rethinking that we should open this up to nurse practitioners. And I think that's coming closer to happen. I was contacted about a week ago by Senator Udall of New Mexico, who's framing a bill but looking for a Republican co-sponsor in order to expand it, saying it really makes no sense. If a nurse practitioner can prescribe morphine, Oxycontin, oxycodone, why can't they prescribe buprenorphine? And and I work with a nurse practitioner in my office who I write her prescriptions, but she's absolutely terrific in getting patients engaged and getting patients successfully to be on buprenorphine. So these were the changes. So for methadone, you have to show up in withdrawal. Buprenorphine, you do not have to show up in withdrawal. You have to have criteria for DSM-4 dependence on opiates. So if someone, for instance, who is released from prison, they feel vulnerable, I can start them on buprenorphine knowing they have a history of opiate dependence. If they were going to a methadone program, they would have to have used and demonstrate withdrawal. Methadone clinic, at least 12 months of use. Buprenorphine, no time criteria, and you can see the other difference as well. Buprenorphine officially is age 16. I have not treated anybody under the age of 21 with buprenorphine, however, but I have colleagues who treat adolescents who have. And again, the rules related to buprenorphine is that it can be written by prescription, so patients bring it to the pharmacy and have it filled. The number of days for me depends on how they're doing. Short-term prescriptions early on, but they can receive up to 30-day prescription. So obviously the route difference. Buprenorphine is sublingual under the tongue. There's also a buccal preparation coming out where it's kind of put against the inside of the cheek. Onset is pretty quick. It says 30 minutes. Some patients report minutes. So if I have somebody who's really sick in withdrawal and they put a buprenorphine tablet under their tongue, they're better within minutes. So these were some of the early studies comparing them. I think the numbers are useful. So this was Ed Johnson, who was at Hopkins at the time, looking at, there was a low-dose methadone also, which I left off because it wasn't effective. But retention at 17 weeks. 17 weeks is pretty short, but I'll show you some other data in a couple minutes. So methadone looks like it's a little bit better. Now, methadone is really a leash. You have to show up every day. Nobody, for the most part, who uses buprenorphine makes their patients show up every day for the first few months. But retention, 73% for methadone, 58% for buprenorphine. LAM is now off the market. But those numbers are about right. As you can see, almost every study that I'm going to present, and even ones I haven't presented, the retention data for buprenorphine is 55 to 60%, meaning people retained and doing well, which is pretty high. I don't know how many of you went to the smoking cessation one yesterday, and this is true for me, and I kind of think I try to work really hard in getting people stopping smoking. I can't get anywhere that number for my patients who even are totally motivated to quit smoking. I'm lucky if I get a quarter of them at a year not smoking. So buprenorphine is a modest mu agonist. It has a ceiling, which means, unlike other drugs, people will say, I use a lot of heroin, don't I need more buprenorphine? And the answer is no, that there's a ceiling effect. I tell, don't compare your dose. We saturate your receptors. For instance, in Australia, most people are only on 8 to 12 milligrams of buprenorphine. Here, most patients are on 16. once your receptors have buprenorphine on there, you don't get more effect by being on more. It has a long half-life. Theoretically, you could dose it every other day, but I tend not to because I think it's confusing for patients. You can precipitate withdrawal, so I always say to patients when I start, when's your last use? And then I specifically say, is there any chance that you took any methadone in the past 24 hours? Because if they say no, and we've only pursued withdrawal a couple times, and they get sick after they take their first dose, that's usually the scenario. Oh, I forgot to tell you I took a sip of my friend's methadone. Very low risk of respiratory depression, CNS depression, except if you take them with benzodiazepines. So all the bad press that some of you may have heard in New York Times a few months ago is people who are using other things as well. The combination tablet in the United States, I think it's the only one that we should use, is with naloxone. Means that you can't generally inject it because you'll get naloxone effect. I've been doing this, for a long time. I ask patients. So I attend our inpatient unit once a month for a week, so I always ask patients there as well. What's going on the streets? How much you're paying for your drugs. There is some, like they may say, sometimes I bought, knowing I was coming for detox last night, I bought a tablet on the street to bridge me so I wouldn't be sick still last night. So most street use is therapeutic diversion, meaning people are using it to bridge into treatment. One sec. I've never met anybody who has injected the combo tablet in Baltimore.
I was going to ask on QT prolongation for
Next slide. Good question.
methadone. Anything on buprenorphine?
Yep. So there was I think it's the next slide. Yeah, there is a next slide. So there's no alteration of cognitive functioning. So many of you, the question was about QT prolongation, which we know about methadone. We still don't know quite what to do with methadone. Some programs routinely get EKG. So EKGs will show, one of the intervals on EKGs could predispose someone to having arrhythmia. The QT prolongation is more common in higher doses of methadone, especially over 100 milligrams. So there was a paper published that large cohorts of people on both methadone and buprenorphine showing that there's no evidence of QT prolongation for buprenorphine. It's especially something to think about if somebody's on other medications that put people at risk for QT prolongation as well, some of the antibiotics, some antidepressants as well. And the other thing to realize is no clinically significant interactions with other drugs. I do HIV primary care as well, and efavirenz, one of the common drugs in medication that we give for HIV, has a profound interaction with methadone. So I'll give you a scenario. So a patient of mine this is years ago, was on this medication called efavirenz. He got on a methadone program, and in order to get the effect, he needed very large doses of methadone because the efavirenz was revving up his metabolism. So he was on like 140 milligrams of methadone. He shows up for a follow-up visit, and he is in the waiting room. I could barely arouse him. He was clearly in opiate overdose. And what had he done after we got him better was he had stopped taking his HIV medication, so now he was seeing a massive dose of methadone, which he wasn't used to. So there are drug interactions that we worry about with methadone. So these are just some things that I think about. Early on, when I first started, I thought of my best patients. Early on, one of my patients, I still take care of people that I initiated. I always thought of people who were working and doing really well. But people to think about as to whether or not they're appropriate. I am fearful of people being on benzodiazepines or other depressants. I'm not so afraid anymore of significant psychiatric comorbidity because I work with other colleagues to make sure those stay stable. But realize that buprenorphine is a step down from methadone, right? So meaning it's not as intensive. But at the same time, I also try to put things in time sequence, right? Most people who have made attempts at recovery have made a lot of attempts. So maybe even though 2 years ago they didn't do well on methadone, is there something about them or the changes they made in their life that would say maybe they're not the same they were 2 years ago, and maybe this is a therapy that could work. So even though that may make you think about it, it's not a definite. I think there's very few reasons to say absolutely no. So these are some of the quotes you'll hear from people on buprenorphine. I feel normal, I wake up not sick, I have my life back. The treatment in normal medical settings, I think, is crucial because it encourages continuity of medical care, encourages relationships, and most important, I think it legitimizes opioid dependence as a normal treatable chronic illness. So for my patients who are doing well, we talk about their diabetes, their heart failure, work on weight loss, and then at the bottom of the list is the fact that they have opioid dependence and they've been doing well for 2 years now. Every urine drug screen has been negative. They go to NA meetings 4 times a week, and they're now working. So that kind of is kind of almost a maintenance problem at the bottom of the list. And that's what you want to happen. So I'm just going to go through a few slides to think about buprenorphine treatment, kind of similar to methadone. This is one of the early studies that looked at people who buprenorphine detox versus maintenance. So early on, a lot of places we were just thinking, well, can you just give 3 to 7 days of buprenorphine without anything else? So this is a study, again, looking at the fact that maintenance can prevent death. Remember, when patients relapse, they're at high risk for overdose, right? They lost their tolerance. So there is no memory for opiate tolerance. Unlike alcohol, where I took a physician who was 17 years sober. He called me, said, I relapsed yesterday, and I've had a gallon of vodka since yesterday, and he was coherent talking to me on the phone. Right? So there's, it's a strange memory of tolerance for alcohol. Opiates have none. Right? So somebody goes back to the last amount they used, they don't have tolerance, and they overdose. So who are the first patients? So this is important to think about. They're different people. So this was a survey in 2003, soon after buprenorphine started being used. 35% of patients were new to substance use treatment. So they had not been in substance use treatment before. So we're reaching a new group of people. 55% had never been on medication-assisted treatment before. A very small number had been on methadone before. So only, I think it was 11 or 12% had been on methadone before. And over half were addicted to non-heroin opiates. So reaching a new group of people. These are some studies that were published coming out. This is 2005 out of Brown. 24 weeks, 6 months into treatment, 59% were still engaged in treatment. Again, that 55 to 60% number, which is amazingly consistent. The other reason I showed you this slide is I'm going to explain, is the top solid line were people who gave an opiate negative urine at week 1. So if you were doing well early on, obviously there's some self-determination. So this doesn't answer, can we make someone have that opiate negative urine at week 1? But I think you have to imply that we should try. But you were 80% likely to still be engaged in treatment at 24 weeks if you had an opiate negative urine at 1 week. So the way I use this is I make strong efforts early on for people to succeed during that first week. Phone calls, other people calling, I bring them back. You want to really work hard to get people successful early, and I think that's an important message. There are some studies, remember this is an opiate blocker, but there's some studies to show that as people do well with opiates, they tend to perhaps do better with other drugs as well. Specifically, cocaine is the one that's been looked at. And these weren't all necessarily, this is published in the New England Journal, these weren't necessarily all people who were injecting them together. Remember, a lot of our patients inject heroin and cocaine together to count for the counteractive effect, right? To get rid of some of the sedation. They want to get high but not as sedated, so you mix some cocaine in. So again, diversion is low. It exists. We should be aware of it and do our best to prevent it. I make patients small numbers. I verify that buprenorphine is in their urine. I may call them back for pill counts to make sure that they have what they're supposed to have still remaining. But compared to other things like oxycodone, much lower. So I'm going to show you my outcomes. I think we're good. So we looked at our outcomes and we published them in Journal of Substance Use Treatment. Again, primary care setting, patients being seen by primary care providers in the context of providing primary care. At this point, 2003, 2007, it was just providers. I'm going to show you at the end how much other things we have, but it was just providers. 15-minute talks, visits. Sometimes we ran over. Frequency, discretion of provider. So, it's tough to exactly say, right? Some patients we saw back every day for 3-4 days in a row. Some patients we may have done a phone call the next day. We generally never start someone on a Friday, right? We try in general to start people Monday, Tuesday, and Wednesday, because we don't want to have something happens over the weekends. We're not open on the weekend. So generally starting people Monday, Tuesday, and Wednesday. We have non-witness urines. Pretty tough in primary care setting to have a staff member who wants to watch someone pee. It's generally not in most of their job descriptions. So we do verify. So there's a temperature gauge on the urine cup. Is it perfect? No. But you wouldn't believe how often someone, it still happens, someone hands in a urine that's 50 degrees and say, I don't think this is good. Or that it could be the urine that's 125 degrees also. When somebody does that, by the way, we say, the reason we're doing this is a tool so we can help you, and I hope that you trust what we're going to tell you as your healthcare provider. So then, don't you think we should be able to trust you in the same way? So that's how we pose it, just so you know. So anyway, our comorbidities: a lot of hepatitis C, about half. Lots of psychiatric disorders, no surprise. HIV, we provide HIV care. We have Ryan White funding, so we have a lot of HIV patients as well. Chronic pain. So at the end of 1 year, so ours is a year, most of the other studies were 6 months, 57% patients still receiving buprenorphine treatment. And we looked at all people. We had a lot of people who early on tested. You still have people intermittently. Like this just happened the other day. Someone who had been opiate negative for 2 years comes back opiate positive, and they said, I had a cold and I took a sip of someone else's codeine cough medicine. And that's just, we talk it, that's just kind of stupid. But overall, over 2/3 of the month-long treatment blocks were opioid negative. Treatment success was a bit higher for non-heroin users. Really, all other demographic variables not significantly different. I want to point, so people who use cocaine as well did as well. Some other studies said that perhaps cocaine users might do as well. They did as well. We looked at the people who who were lost. 63 were lost to follow-up. We hoped the number would be lower, and I think our numbers, if we looked at it in the last 2 to 3 years, our numbers are much lower in terms of lost to follow-up. For a lot of reasons. We also link people. We have community health workers to get people re-engaged. But 10 lost insurance, 21 discontinued, 8 transferred to methadone maintenance. So one of the things that I think is important as you do this is having great links back and forth. So I'm in one part of a building. The other side of the building has a methadone program. I'm very good friends with methadone providers in my building, as well as the Broadway Center, for those of you at the Broadway Center. And we can easily say, I can make a phone call and tell a patient, you're really struggling. What do you think about methadone? I can make a phone call and say, I have a methadone intake for you scheduled later today. So that's, that's how quickly it can happen. And the reverse happens as well. So my colleague at the methadone program 2 years ago called me and said, I have a woman who's now back in college. She's been on methadone for 3 years. She's getting married. I would like to taper a methadone and ask your help in getting her on to buprenorphine. And that's a common scenario as well. And that woman now actually graduated from nursing school in December, is now working at shock trauma as a nurse. She's actually now off buprenorphine, and she's married and very successful. So it can happen both ways. But I always say to patients, intensifying therapy is never punishment. So if I see someone who's struggling, I say, I think you need to go to more meetings. That's, there should never be anything that sounds like punishment as we try to get patients' lives to get better. So I always say that it's not, you're struggling, we need to find something else to make you succeed. We did have 3 people on overdose, after leaving the program. None of them were receiving buprenorphine at the time. We retrospectively found out they had overdosed. 1 patient died of AIDS and 1 cerebral hemorrhage. So what about methadone versus office-based buprenorphine? So we decided the same cohort of patients. In fact, I just got an email about an hour ago to go over the proofs. So this is a paper of a study that I did with colleagues at the methadone program, again in my same building with Van King and Robert Bruner, looking at consecutive patients, methadone versus buprenorphine. So these were patients that they selected which modality of treatment they wanted. But they showed up in the same time frame, so 252 consecutive patients, similar time frame, same building. So 252 were our primary care patients. Some of them may not necessarily have come saying, I want buprenorphine, but they're there for primary care, and they know that we're a primary care program that focuses on treatment with buprenorphine, and patients that chose methadone. So interestingly, there are a lot of similarities. Mean age was just about the same. The methadone group was a bit larger, and I think that part of that is included women for scent addiction pregnancy. Insurance, tremendous difference. So 41% of our patients have commercial insurance. So we take care of a lot of patients here. You can see at the bottom, 45% of our patients work. So a lot of those patients, I think, chose the program they wanted based on those things, right? So of how they wanted to receive treatment for opioid dependence. You can see unemployment, our program, 29%, methadone program was 72%. And then you can see the other insurances as well. Very few, we do have some grant funding, but only 3% of our patients are uninsured compared to 39% that arrived on methadone. And you can see the substances of abuse. Heroin was similar. Remember, they could be both. So we have a lot of patients who abuse heroin and prescription opiates. But you can see 29% of our patients abuse prescription opiates. So I'm going to say the numbers for heroin are actually increasing as we see more and more suburban and working class people who can't find oxycodone actually shift to heroin. And heroin is cheaper on the street than pills. So I think we're going to see actually a shift towards more heroin. It's interesting. In fact, benzodiazepine use is a very small problem in our patients on buprenorphine. That continues to be true into 2014. I'd say less than, I'd say maybe every couple months we even see a urine tox that's positive for benzodiazepines. So very different than methadone programs. Injection drug use is pretty similar. HIV, we are an HIV clinic, so we see HIV patients. And you can see recent criminal charges. Just realize that even for us, so there's a lot of recent criminal charges. These are criminal charges within a year. So we looked at opioid negative months. So methadone, in a way I'm not surprised, was a little bit better. I show you that early study from the New England Journal showing that methadone was a little bit better. Greater than 6 opioid negative months, 62% on methadone, 46% on buprenorphine. So those, and in treatment at 12 months with more than 6 opioid negative urines, methadone a little bit better than buprenorphine. But I'm going to show you the fact, interesting that we then decided to look at when this happens. I think that's the next slide. It's the slide after this, I'm sorry. So methadone was a bit better than buprenorphine in success. The other predictor, by the way, was recent office opiate treatment program. So you've been in treatment recently and you're trying again, you actually did okay, which also says that people change, and in the scheme of things, most patients make a bunch of attempts before they succeed. So this is a slide. I'm going to stand back here, but just to help you interpret. The main thing is to realize at 12 months, methadone and buprenorphine were pretty similar. So the top graphs are buprenorphine opioid negative and methadone opioid negatives. So at the 12-month point, the numbers were both between 75 and 80%. So if you stayed in the program at 12 months, the likelihood of producing an opioid negative urine for both was the same. Similarly, on the bottom two graphs are in treatment. So at the 12th month, if you look at people in the two programs, our program was about 58%, and methadone was just over 60%. So it's pretty similar. So methadone perhaps a little bit better because of structure, but at the same time, there's a difference in who the patients are. So the conclusion that we decided to come up with was methadone maintenance office-based buprenorphine serve different populations. Both are effective, but outcomes were a little bit better with methadone. So if you look at the Cochrane Review, interestingly enough, the Cochrane Review says the same thing, that these are two great therapies, but methadone probably is a little bit better. The beauty of buprenorphine is that I can do it in my primary care setting. I can't do methadone directly in my primary care setting. So one thing to think about is for lots of medical problems, we have more than one treatment, right? We have lots of different antihypertensives. Some people respond better to one than the other, but we don't always have to say that one is better than the other. Or as Eric Strain, who's a colleague of mine, says, it's like saying that one of your kids is better than the other kid, right? They each have their good qualities, they each have their bad qualities, but we're glad we have both kids. So that's kind of the perspective to think about. So what about the health system impact? So I had said that I think it's all, we think about individual outcome, and what about health system outcomes? And that's where I've decided to turn for the next year or so. And this is some earlier data. Yesterday, someone in the audience was actually from Priority Partners. So Priority Partners is a Maryland Medicaid MCO, and Allison Schuster, as part of her thesis, was working on this data. So thank you, Allison. And so it was a 3-year period of this one specific Medicaid group. And these aren't just my patients. So all my Medicaid patients indeed have Priority Partners, but this is overall. So just under 1,300 people who received a prescription of buprenorphine. You can look at the average age. Interesting, 2/3 women, which I'm not sure I would predict. Over half were white. A little over 1/3 Baltimore City, which I was surprised. I thought it would be much more Baltimore City. 32% rural. So 1/3, and obviously the rest were suburban. It was how, based on zip code. Methadone was about twice that number. Average age was a little bit older. I wasn't surprised, actually. Our age was about 39 also. Again, mostly women, mostly white, over half Baltimore City, and much less rural. There are less methadone programs in rural areas. And then there were people who at some point during those 3 years were both, and the both really just indicates methadone. The numbers are too similar. So this is small, but I'm going to interpret it for you. So at this point, this study was aimed to look at utilization. So it looked at two things, ER visits and admissions to the hospital. So in terms of ER visits, methadone and buprenorphine were similar. And then it compared both methadone and buprenorphine to historic populations of people with opiate dependence who had not received either buprenorphine or methadone. So if you were not on methadone or buprenorphine, compared to being on buprenorphine, you were 1.57 times more likely to have an ER visit, and compared to methadone, it was 1.5. So they're pretty similar. So you're about 1.5 times more likely to have an ER visit. And then the bottom is looking at admission to a hospital with a medical diagnosis. So these aren't detox admissions, or these are medical inpatient admissions. Buprenorphine was a little bit better than methadone. And no agonist versus buprenorphine, you were about 1.87 times as likely to be admitted to the hospital, and no agonist for methadone, 1.4. So these treatments decrease admissions to the hospital, and they decrease ER visits, with seemingly buprenorphine a little bit better at preventing admission to the hospital. So I just received IRB approval. It's a long process, about a week ago. And we're going to actually look at specifically populations looking at cost data now. So costs of health care per member per month for patients receiving buprenorphine, methadone versus no therapy. And actually some specific look at patients that we treat in our model, which I'm going to show you in a minute. So I just want to give you one thought. People say, well, shouldn't we be providing counseling in the primary care setting? And this paper also looked at duration. This is a paper that was published only about 2 years ago, in December of 2011. It's a large study of 653 people. I'll take you through a quick 2 weeks of the combo product, then 2-week taper, 8-week follow-up. If you're successful, you're good. If you're unsuccessful, you could get back on the buprenorphine for 12 weeks and tapered and followed. No matter what you did, you were randomized to standard medical management, but the people providing standard medical management were people who could prescribe buprenorphine and provide counseling, versus that plus an outside counseling. During phase 1, only 6.6% of people did well. So 2 weeks is not enough, is the message here, that we know longer term is needed. So everybody else, so those 610 that were left, went back into phase 2. Half of those finished phase 2. Again, separate counseling didn't matter. At the end of 12-week follow-up, 8.6% were successful. So 12 weeks wasn't enough either. That's why when people ask me when I start them on buprenorphine, how long should I be on this? I say, I don't know. But the answer is usually over 3 months, right? 3 months wasn't enough. The one exception I can tell you is I have patients in recovery who have had surgery. I took care of a gentleman who was in recovery 15 years. He had a total hip replacement. He was on opiates afterwards. He said, I don't know that I can get off this by myself. And I treated him with buprenorphine for 2 weeks, and he was fine. But I don't know how long to treat people. I've tapered many, many people, but generally it's months to year. And usually there's some convincing of why we should consider it at some point. If I do taper someone off, I make sure they still stay in contact frequently because they still need the support even after they've come off. Again, I see patients often. I strongly encourage NA, and I use it often. So I said the data didn't show, but I still think there's a subset of people who benefit from additional counseling. And there's some of those patients that I've identified, and these studies can't identify them because they're randomized studies, and they don't assess for this. So I take care of a lot of people with pretty poor coping skills, a lot of women with intimate partner violence, PTSD, and for those people, I think they need additional help. And I think that if we don't address those other factors, they're more likely to relapse. So we can open for discussion. I think I have 2 or 3 more slides. So this is when I started my practice in 1994. So the way I started my practice is I was did my training at Hopkins Bayview, then Francis Scott Key in primary care. I'd done a chief resident year, and then I joined the faculty and was asked to medicalize our detox unit. And then I realized that all these, my passion was primary care, and all these patients need primary care, and they didn't like where they were going. I presented to my chief of medicine and got some support. I got a room. It was me, a medical assistant to help me, and a person who helped register people. And that's how I started. And as it became known that I was seeking to provide primary care to patients in recovery or with addiction, all of a sudden the sister of the president of the hospital became my patient because she was battling alcoholism. And then someone in the dean's office became my patient because they were battling addiction. And it was no surprise. And then about a year later, we were too big for our space. I was asked to present to the Board of Trustees of Hopkins Bayview, and lo and behold, Ron Peterson, who's now the president of Hopkins Healthcare, gave essentially $1 million and said, I'll give you a practice. And we took over the old Highland Health, I don't know if you remember State Highland Health, which was in the Mason Lord building, with a huge renovation. It was pretty exciting because I actually got to design with an architect how I wanted my practice to look. I didn't want to talk to patients in exam rooms. I wanted office settings because most visits I never bring my patients to an exam room, or if I do, it's 2 minutes of their 20-minute visit. So that's how we came to be. This is me now, so I'm just going to take you through this. So 2014, so I now have 5 physician providers. I have a nurse practitioner. We have 6 resident physicians rotating who are interested in primary care and urban health. We have urban health residents rotate with us also. Related to providing HIV care, I have an HIV-specific case manager. She's incredibly knowledgeable to get people help with housing. She can get people same-day coverage for HIV medications. We can see illegals who don't qualify for medical assistance. We have 2 nurse case managers, one for Medicaid population, one for Medicare population. They do everything possible to help our patients succeed. If our patients are hospitalized, they go see them, even at outside hospitals, and make sure they have an appointment to bridge them to when they're going to see us back. We have a health behavioral specialist who's an LCSWC who Monday mornings I'm at Dee's place in East Baltimore. I had met her there. A program had come down. Her expertise was specifically related to women's issue and PTSD, and intimate partner violence was exactly what I wanted, so she joined us a little over a year ago. It's not unusual, for instance, that I could think of one specific patient. She comes in every 2 weeks. She sees our health behavioral specialist 8 to 9, sees me 9 to 9:15 or 9:20, and we try to bridge things together. We have 2 community health workers, peer counselors. They're both in recovery. They take people to AA or NA meetings if they have never been or if they need help. Patients don't show up for visits. They go out and find them. One of our community health workers found one of our patients living in a car. One time, one of our patients didn't answer the phone. He went to her home, and she was in crisis. So they're enormously useful. I should say we also have team rounds once a week. We all run into each other all the time, but every Wednesday morning we have team rounds with the community health workers, health care specialists, case managers, where we come up with plans related to our patients, and we all refer to ourselves as that patient's fan club. We have a pharmacist who's linked. She's actually in our setting on Friday afternoon, so if patients need to learn how to give injections or need help with adherence, she's there. She helps us get prior authorization, which is something that I hate. So one of the stumbling blocks I didn't mention, I think, to providers providing buprenorphine is that there are many insurances that require prior authorization. She does it for us. She also arranges for home delivery for patients during bad weather. So if there's an obstacle transportation problem, she can help get medications delivered to their home directly from pharmacy. We have 3 medical assistants. We have on-site phlebotomy, so patients don't have to leave our office setting. So, they met with the health behavioral specialist, they meet with me, they go get their blood drawn, and then they go meet with the last person, which I'll tell you about in a second, and then we have patient care coordinators as well. Anybody know what health leads is? Good. So health, have you heard of health leads? No, health leads. So health leads is a program that originated in Boston. The originator won a MacArthur Award. So we have a desk. So in Baltimore, there's one at the Harriet Lane Clinic and also University of Maryland Pediatric Clinic as well. We're the only adult primary care clinic in Baltimore that has a health leads desk. So it's a team of volunteers led by someone who works for health leads, who helps link patients in active time and real help for determinants of health that you may not think of. So we get patients help with food stamps, with food pantry, housing, dental assistance, GED, legal assistance, and it's all real. It's not just here's where you have to go. So for instance, if somebody needs help with food, fuel fund also, but let's say they have no food, we link them to a food pantry. One of our community health workers can take them there, help them pick up their food, and then get them home. So it's really looking at other determinants. So as a primary care provider, I can prescribe. So I'm not just writing prescription for medications. I can prescribe help with food. This person needs help getting their GED. This person needs help with vocational training, and they're linked. So they meet with our health leads person. They get the person who draws their blood knows then to bring them to the health leads desk, and they meet with the health leads desk. There's then active phone conversation, active follow-up, and nothing is ever closed unless there's actually a closed loop of how they've received help. We're actually, again, we're only a few months in, and we're looking actually as part of this to do research also, because we think this is important, and there are studies that look at these things as determinants of health, but we're actually going to look at outcomes based on our patient interactions with health leads.
I didn't see it up there. Do you also do any prison to community transferring kind of services?
Explain.
People coming out of prison or jail and they need services and they're referred to you?
So the answer is yes. So I have a lot of, so it's not unusual to get a text from a judge, by the way, asking, both federal and local, asking to try to get somebody who's being released linked to care. So the answer is yes. It goes the other way too. I very well know people in the prison system too to verify patients' doses of medications. So our patients go the other way as well. So yes, we do have linkages.
Do you work in conjunction with any drug courts or have patients who are also currently in drug courts?
So the answer is partially yes. So drug court, so 2 floors down from me is our vocational training program. So those people usually arrive from drug court. So as alternative drug court, they actually have to give clean urines in order to enter the workplace. So it's contingency there also, but it's actually vocational training. So that's in my building as well, 2 floors down. Related to that program, which I haven't touched on, which is off topic, but I'm going to mention it, is that we also have a Staying Alive program. where we teach people in recovery and family members to use naloxone for opiate overdose prevention. And I'm a strong advocate of naloxone being everywhere. It's nasal naloxone. I think if every house in Baltimore City has a smoke detector, every house in Baltimore City should have a naloxone kit available as well. That's me. I have to leave. We have 2 minutes. So my patient, I'm sorry. So I just saw her actually early at the beginning of this week. She's now 2 months in. I've seen her 6 times. She's had some meeting with our health behavior specialist as well. She's on medication for hypertension, did her PAP. We tested her, most importantly, for viral hepatitis and HIV, which were negative. She's working on weight loss. There really wasn't a lot of convincing, I should say. So when I took the course, when I taught this yesterday, people asked what was her reaction because our agendas were different. I let her know I looked up in CRISP. And I said, I think I kind of said, I think you have a problem. I use the system, and I could see that you've been seeing a lot of providers. You're getting oxycodone from a lot of people. This seems like a problem. And then, as happens most of the time, she says, yeah, I have a problem. And there was no more focus on pain. It was a sense of relief. And I'd say at least half the time, I always teach residents that you raise your anxiety. Oh my God, what's she going to say? And then the response is a sense of relief. Wow, this is someone who's not going to think I'm a bad person, that they want to help me, and they know what I've been going through. So anyways, so she's doing well on buprenorphine naloxone. No reported back pain. Urine drug screens all negative since that first visit. So, I saw her a few days later. Urine was negative for opiates. She's going to NA3 meetings a week. She has kids. It could be, I kind of wanted more than that. But she's met with a health behavior specialist as well, related to especially some self-esteem issues, much improved, and better relationship with family. So I can't emphasize, I want to end with that note too, because I think these guys are the guys that really helped us realize how to think about our patients with addiction, and that's Dr. Bob and Bill W. So obviously, Dr. Bob was a physician, so a physician helped found AA, right? Stockbroker and a physician, sitting in an Akron, hotel lobby bar, held their first AA meeting, and these guys, I think we're all grateful to these 2 guys. So thank you. Comments for each other, even.
Yeah, thanks for giving us the snippet about the AA. Thank you. I know how valuable that is in what I do, being a provider. How about it as far as use of buprenorphine in pain relieving qualities?
So I take
higher doses are supposed to be.
So I don't know. So it's interesting. So I take care of a guy who builds fences, who really needs a knee replacement, but says I can't go out for stop working and get my knee replacement, and he's on buprenorphine, and he's on 4 milligrams 3 times a day, and he says I get great pain relief. I make it through my work day. He's on it for opiate dependence, and we decided, the analgesic half-life is different. So for him, but again, not a lot, and he says, I make it through my day. So strictly speaking, it's an off-label use, which I'm not supposed to say, right? But at the same time, people do report pain relief. I have another woman who has opiate dependence, and she had been on methadone. She didn't want to be methadone anymore, but she had this unclear neuropathy pain. She said loads of studies, EMGs, nerve conduction studies, miserable life, and she reported that my neuropathic pain, she's also on, she's on 16 milligrams a day of buprenorphine, and she says, again, my nerve, I'm able to function, and this is so much better than being on methadone. For her, everybody's different.
I was looking at your list of things that you need as a primary care person to be able to mount this kind of an effort. What do you do if you're in a small town in a rural area?
So I showed you how I started off. So I think the latter is pretty amazing to think that we were able to put this together. But I think the first, so I'll give you a story. So over the years, we have had residents rotate with us. One of them is a guy rotated with us about 10 years ago. He spent 2 years with us as a resident. He's now in rural Kansas as the only buprenorphine provider for like 100 miles around. And he takes care in his small office in rural Kansas. He takes care of his 100 patients effectively. There's a long list of people waiting to seek help from him. It's mostly prescription opiate abuse. So it's certainly doable. So the data that I showed you where we had 58% retention, that was just providers with nobody else. The other pieces I think, help in terms of overall health outcomes, but in terms of purely being able to do this in terms of treating dependence. Can we make every physician want to do this? No, I've learned that as we've tried to go into some community health centers in Baltimore where if providers say, I don't like people with addiction, I don't want to take care of people with addiction, it's pretty tough to get them to want to do this. But if you want to do this and you want to become the patient's fan club, you can do it.
I really have two questions. The first has to do with your colleagues, and now that they have the PDMP information through CRISP about patients' doctor shopping or opiate prescriptions, what's your sense about what they need in order to support the interaction with the patient around that information?
I tell patients, it's very beneficial. I mean, I take care of patients where outside of trying to catch somebody, a patient was recently hospitalized in another hospital, and I want to know what their X-ray study showed. So I always show patients that I'm using it. So it may for them to see that there are very beneficial reasons to use it. And even in the woman I said, this isn't it's for your safety that this is concerning that you're going to a lot of ERs. And I hate ERs. So I usually say ERs can be a really bad place for you because sometimes you get tests that you don't need. That's why I look in the system, and I think it's to everybody's benefit to be able to see these things. So I always spin it as a positive. I don't ever try to tell patients, hi, caught you.
Like you advocate for patients coming for frequent visits, touching base frequently, and all of that. And I've heard more than once where my patients want to go somewhere else for treatment because they think that transitioning to a primary care physician means that they get a month's worth of script and then they get the freedom to do whatever they want within that month. And I'm just wondering.
Eventually that happens. Eventually that happens, right? So I do take care of many patients who come monthly, but early on, I make sure patients know what the expectation is. I didn't go through, we have a patient treatment agreement where people understand that there's going to be frequent visits early on. We talk about safeguarding medication when people have kids at home. So there's the initial visit has a lot of discussion of what's expected.
Thank you very much for an excellent presentation. I was wondering if you could speak to Suboxone strips. I work in a correctional facility. It's the main drug of choice in our facility. And actually, I just had an inmate I was interviewing last week who said the pharmacy company must have made strips specifically for the correctional facilities because it's so easy to smuggle into the jail.
Yes. So generally, we use tablets. So I was asked my opinion by Priority Partners. So for Priority Partners, only the tablets are formulary. They're just as effective. Patients may say, I don't like the tablets, I don't like the taste. I'm worried about the strips as well. The tablets also, the generic tablets for the cost to Priority Partners is a little over $2 a tablet. The strips would cost them $8 a strip as their wholesale cost. So as a result, and maybe this is a hidden motive, but we talked, they said, would you support us just, without prior authorization saying that the tablets are formulary? And as soon as I heard without prior authorization, I said, absolutely, absolutely. But they're just as effective. And I worry about that. You're correct. The strips are very easy. There's in the story in the New York Times, they showed, I think, a piece of a strip on the back of a postage stamp and a letter that went to the patient, went to the client. So I'm concerned too.
We only have a few physicians in the middle of the Eastern Shore prescribing buprenorphine. I have two questions. Do you take clients from a distance?
Go ahead. That's the second.
My primary care physician may have an interest in getting involved, are there mentors?
Yes. So I'll answer that first. So I'm an internist, but I'm a mentor through the American Academy of Addiction Psychiatry. So there's something called PCSS. It used to be PCS. So if you look up, if you go to the American Academy of Addiction Psychiatry website, you'll see a PCSS link, and you can be assigned a mentor. So there could be mentors. For a while, it was separate mentors for buprenorphine versus methadone, and now it's medication-assisted therapy mentors. So you can choose. And the question about Eastern Shore, I do see patients who come a fair distance. What town are you in?
Eastern Maryland.
Eastern, okay. So just 2 weeks ago, I was attending on an inpatient unit. We get a fair number of patients from the Eastern Shore now for seeking help. And as I learned from a young woman who lived in St. Michael's, when I asked her what she was using, she goes, "We got lots of heroin here in St. Michael's," which was to my surprise. She said, "It's a little bit more expensive, but it's cheaper to get it here than to have to drive into Baltimore to get it." So we're seeing, as I alluded to earlier, more and more heroin in away from urban areas because it's cheaper than oxycodone.
Actually, it's a great segue because we've been examining a model that they're using in Ohio to do buprenorphine through telemedicine.
Yeah.
And
it's other states as well.
so the on-the-ground in the location is the nurse
Yeah.
and the counseling staff, the support, and the doc is via telemedicine. What do you think about that?
It's a model. There's a model in New Mexico, the ECHO model, where they use that for HIV treatment, hepatitis C treatment as well. I mean, if there is otherwise an inability, I think it's something to think about. To me, it's not the same. I like to have a patient in front of me. I like to read nonverbals. So I kind of miss some of that, but I wouldn't dismiss it. You got a question too? Oh, say one in the back.
This is threefold, if I may.
Okay, you have to remind me the three though.
Talk about treatment involved for the new patients. What does treatment involve other than just counseling as opposed to treatment for addiction? And how long is it? How long do patients stay on the BEAT program? Because methadone, here in this area, people can stay on it as long as they're compliant, which means 20 years.
Yeah.
So that's one. The other.
Let me answer that one first,
Okay.
because it's involved. So I alluded that I don't necessarily know the answer. To me, the key is what have they done to make their lives more stable? Have they improved coping? Have they improved self-esteem? Have they put some structure in their life? Have they changed people and places? So I have had many people transition after a year or two. I have some people who have been on 7, 8 years, because I think that everybody's a little bit different. Some people probably have a different new receptor that they're doomed to fail, unfortunately, if they don't have buprenorphine and methadone there. Some patients, I always say like diabetes, right? Some people who are diabetic have to stay on medication the rest of their life. Some people can lose weight, exercise, and come off their diabetes medication. So I'm always open. Patients, we think about how people are doing. I had a young woman, again, who about a year after really putting her life together, we tapered her off and she did well. But I think I totally individualized. And the treatment really is, it's the conversation, it's the changing people and places, it's putting people's lives together. It's all those pieces I think that you all know that go into recovery. 2, sorry, we have a minute.
When you talked about folks being employed, how long does that stay in the prison system? Because methadone shows up when folks have their urinalysis for jobs.
Correct.
Often they're turned down as a result of having an opiate indicator.
So most drug testing does not include buprenorphine. So you have to test for it separately. And so if you look at for life insurance even, or those other things, buprenorphine for drug testing is generally not included. Although, I never know quite the right answer of what patients, if patients ask me, should I tell them I'm on buprenorphine? I'm not sure. I take care of 2 nurses in recovery who are on buprenorphine, and the nursing board knows they're on buprenorphine.